Hello, I'm Elizabeth Chizado, and in this presentation, I aim to study the differences in the occurrence of type 2 diabetes among adult Indigenous and non-Indigenous Australians from 2013 to 2016. Firstly, I would like to acknowledge the traditional custodians of country throughout Australia and recognize their continuing connection to land, waters, and community. I pay my respects to them and their cultures and to elders both past and present. Diabetes is a chronic condition in which blood glucose levels become too high due to the body's inability to produce enough insulin or the body becomes resistant to insulin. According to the Australian Institute of Health and Welfare, diabetes heightens the risk of developing a number of serious health problems. This includes serious diseases affecting the heart and blood vessels, eyes, kidneys, and nerves. Poor control over diabetes may ultimately result in increased medical costs, disability, mental health problems, reduced quality of life, and shortened life expectancy. In 2017 to 2018, 1 in 20 Australians, 4.9% or 1.2 million people, had diabetes. Since 2001, this rate has increased from 3.3%, however, it has remained relatively stable or slightly decreasing since 2014 to 2015, 5.1% as shown in the chart. Specifically, 144,800 people experienced type 1 diabetes and 998,100 people experienced type 2 diabetes in 2017 to 2018. With that being said, this life-threatening disease has been ranked 7th in the leading causes of death. It has reached epidemic proportions worldwide and poses as a challenge for public health systems. Unfortunately, there is a population group experiencing the burden of disease more than others. Chronic diseases such as diabetes are responsible for more than two-thirds, that is, 70% of the gap in disease burden between Indigenous and non-Indigenous Australians, and it is a major contributor to the 10 to 20 difference in life expectancy compared to non-Indigenous Australians. To be specific to the purpose of this presentation, Indigenous Australians are 4 times as likely to have type 2 diabetes prevalence, hospitalization, and death rates, and incidence rates were 3 times as high among Aboriginal and Torres Strait Islander Australians than their non-Indigenous counterparts. The following is the data visualization of the incidence of insulin-treated type 2 diabetes among different population groups, with Indigenous and non-Indigenous Australians as the first group presented in the charts from 2013, 2014, 2015, and 2016. You can clearly see the extreme gap or disparity between the two population groups over the course of these years with no signs of improvement. Therefore, it is important to address this public health issue and to discuss initiatives to prevent or control it. The largest contribution to the Indigenous health gap occurred among people aged 35 to 54 years old at 35%, followed by 15 to 34-year-olds at 25%, 55 years and older at 23%, and then children under 15 years at 17%. Diabetes is one of the main contributors to the health gap at age 35 years and over. The potential risk factors contributing to the development of diabetes among Aboriginal and Torres Strait Islander people reflect a combination of historical, social, cultural, geographical, economic, and community factors, as well as behavioral and biomedical, and the government health policies and services. Within the historical context, Aboriginal and Torres Strait Islander people have undergone major changes in lifestyle since the 18th century. The traditional activities related to gathering food and resources and familial, cultural, and spiritual practices have been adjusted to fit the new social structure or slowly eradicated over time. Studies cited by Barrow and Ride found a significant correlation between the development of a westernized lifestyle and the levels of diabetes in the Aboriginal and Torres Strait Islander population. In contemporary society, economic growth, geographical influence, and social conditions are major contributors to the health outcomes experienced by individuals and communities. These factors are measured in education, employment, income, housing, access to services, connection with land, racism, and incarceration, all of which are experienced by Indigenous populations more so in comparison to non-Indigenous Australians. There are non-modifiable risk factors for diabetes such as family history and age. However, there are modifiable risk factors, behavioral or biomedical, and can be amended through behavior and lifestyle changes or use of interventions, hence modifiable. Behavioral factors include tobacco smoking, low levels of physical activity, and poor nutrition, whereas biomedical risk factors are present in the body such as impaired glucose regulation, high blood pressure, high blood cholesterol, and obesity. This is applicable to both populations. In spite of the abundance of reports recording the health disadvantage experienced by Indigenous Australians, setting priorities for Indigenous health development remain a challenge. The following slides are 5 main preventive strategies or interventions found to have impacted on the development of Indigenous health or the areas that need improvement. Design attributes are crucial elements to build a solid foundation for successful implementation and sustainability. Community engagement and ownership of interventions by members have proven to improve adherence and sustainability. Tertiary prevention involves support groups and programs that allow community members to share strategies for living well. Sufficient resourcing of primary prevention programs may influence on life modifications. For example, with a sedentary lifestyle, development of sport-based interventions for diet, nutrition education, healthy cooking classes, and store tours to identify the healthy food choices. However, considering the issue of socioeconomic disadvantages for access to healthy foods make this more complex. Smoking counseling or non-smoking policy in public areas, and other policies and funding for the environment. It is essential to consider the recruitment of staff with suitable training and competence, inclusion of Indigenous health workers, and support staff well-being. The inclusion of Aboriginal health practitioners is vital, as their guidance may enhance careful implementation of culturally safe practices and acceptable interventions, as well as safe communication between healthcare providers and patients, thereby improving the delivery of diabetes services and care. Building patient-provider relationships require chronic disease workers to be understanding, supportive, empowering, communicate sensitively, and allow the patients to take control of their own health and make their own decisions as they are partners in care. This relationship is sustainable and is valued by both parties. Inadequate identification of Indigenous status and lacking awareness of available external health services inhibit the ability of primary care providers to access the best and appropriate care for Indigenous patients. And lastly, a component critical to the improvement of health for Indigenous populations is access to appropriate, affordable, acceptable, and comprehensive primary health care. Primary healthcare plays the main role in implementing interventions for health promotion, secondary prevention such as regular diagnosis and screening exams, and management of chronic conditions such as diabetes. These factors I mentioned were found in a systematic review in 2015 which synthesized international evidence to investigate the factors enabling or inhibiting the impact of interventions aimed at improving chronic disease care for Indigenous people in the primary health care setting. In using databases such as the Department of Health, the Australian Institute of Health and Welfare, and the Australian Bureau of Statistics, I was able to find the appropriate data and figures on the measures of disease. But most importantly, I used the PubMed platform, a free search engine that accesses the Medline database to find studies covering the preventive strategies and interventions mentioned previously. The following are the search terms used. These terms were searched for in the article title, abstract, subject heading, and keywords, and the search covered for the time period from 2013 to 2019. Evidence-based practice ranks study types based on the strength and precision of their research methods. As seen here, systematic reviews are on the top of the hierarchy of evidence, which is what I have used in this presentation. However, it is important to address the biases or limitations of the review. Firstly, this systematic review aims to evaluate literature at an international level. Although the vast majority of studies were Australian, which is beneficial for this presentation, data and relevant conclusive results may have been missed. Much of the research in this review represented the perspective of the service provider, less so that of the patient and the community, and least of all, that of the policy or decision maker. Therefore, further research is required. Access to appropriate, affordable, acceptable, and comprehensive primary health care, diabetes management programs, and community involvement are all crucial for the improvement of Indigenous health. The complexity of these elements remain challenging in today's public health systems. However, the exceedingly evident fact that higher prevalence or occurrence of type 2 diabetes among Indigenous Australians than their non Indigenous counterparts demands for enhanced screening to identify and treat those at risk of developing diabetes. This may assist in dictating how resources should be distributed and where improvements are needed most. Additionally, it may also contribute to the clarification of the common misconception that burden of disease is experienced across all of Indigenous Australia. Thank you.